Invite upon stage Dr. Ramesh AYYALA. Sir is the keynote speaker for this session. He is the professor and chair of USF Eye Institute and James P. and Heather Gill's chair in ophthalmology at the University of South Florida, Tampa, Florida. Prior to that, at Tulane University, Dr. AYYALA was a tenured professor of ophthalmology, director of the Glaucoma Services, and director of Glaucoma and Anterior Segment Fellowship Program. Born in Hyderabad, India, Dr. AYYALA completed his medical training on 3 continents. He has been awarded with many honors for his teaching, and we are fortunate to have him teach us here today. So please.
Thank you. Dr. Godre, right? Dr. Godre?
Yes.
Yeah, Dr. Godre and Dr. Radhika, thank you for the invitation. I am honored to be here as part of the teaching session. As was introduced, I did both cornea and glaucoma. Even though glaucoma was my main passion in life, I do a lot of cornea work that is related to glaucoma. And Dr. Sathe has beautifully explained how to manage glaucoma in the presence of cornea transplantation. In fact, the #1 reason why cornea transplant patients go blind is because of glaucoma. Is it ready now? So these are my grants in support, and none of them really affect this talk. Can you hear me? Yeah. So cornea diseases and glaucoma are seen together in almost 50% of all glaucoma patients. Cornea issues in glaucoma patients mostly have to do with endothelial decomposition with resulting corneal edema. Glaucoma issues in cornea patients can be of 4 reasons. Congenital, you can see mesodermal dysgenesis with glaucoma in almost 50 to 100% of the patients. Acquired PKP, we just learned 30 to 50% of those patients will develop glaucoma at some point. So you got to know how to manage glaucoma, diagnose glaucoma, and treat glaucoma in these patients. Inflammatory trabeculitis with HSV keratitis is an outstanding example. And traumatic, we heard a lot about how trauma can affect these patients and resulting glaucoma. Here is an example of a congenital glaucoma, mesodermal dysgenesis. This baby was brought to me when she was 3 weeks old with sclerocornea, bilateral sclerocornea development, has a family history of it. So we didn't even know where the limbus was. I did a 6mm trephination, freehand trephination for this baby. I did a cornea transplantation. And at the same time, because there's no limbus, you can assume that this baby, even though at that point in time the pressure was okay, will develop glaucoma. So I went ahead and put a AMID pediatric valve. This baby, I just recently saw this baby after 5 years. The graft just about failed recently, and she developed an underlying cataract, so I took the cataract out and did another transplant on this baby. It's very rewarding to do this kind of work. It's don't ever give up on these pediatric patients because that's God's work, really. There's not much money involved in this, a lot of anxiety from the parents and the grandparents, etc. But it's so nice to see these kids. This little kid actually can read. She goes to school. She stands first in her class. And she posts all the time on Facebook. And I follow her on Facebook, and she follows me on Facebook, and it's so very rewarding to see these kids develop. So don't ever give up on these pediatric cases. It's very challenging doing I don't know how many of you have done pediatric cornea transplants. It's very challenging. These transplants fail frequently, and it's frustrating because you got to take them back every so often to put them to sleep under general anesthesia and examine them. And the rest of the valve surgery is very similar to what was shown. Essentially, pediatric AMID valve is what I tend to use and suture it at the end of the day. She has done well, and I'm happy for that. Now, penetrating keratoplasty, glaucoma is the leading cause for permanent loss of vision in PKP patients. We have published extensively on this in many venues. So the pathogenesis, Zimmerman, along with Arvin and Kaufman, back in the day have described the pathogenesis for this mechanical collapse of the TM, especially in aphakic patients, is the reason why this happens. As perfusion studies have suggested, full thickness sutures, this normal outflow, but if the depth of the suture is less than 30%, then the outflow resistance is increased to reduced to 37%. So you got to be aware that the incidence of glaucoma is very high, especially in the presence of perforated corneal ulcers, trauma, inflammation, blood or visco in the AC, tight sutures, long bites, larger trephine size, and smaller recipient corneal diameter. So please don't ignore glaucoma. Like I was saying, the number one reason why patients with cornea transplants go blind is because of undiagnosed or ignored glaucoma. Always make it a point to check their intraocular pressure. Various techniques have already been described. I'm not going to go into them. Use simple techniques. If you have a tono pen, use the tono pen. If not, even a Goldman, however irregular the surface is, you will get an idea when the pressure is high. And the other trick is to use the other eye, digital technique, and you compare the normal eye to the abnormal eye, you will get a feeling as to whether the patient has glaucoma or not. But one thing you should not do is to ignore it. And if the optic nerve is visible, serial optic nerve photography or diagrams or OCT measurements, even if the patient cannot do Humphrey vision field, is very useful for you to make a diagnosis of glaucoma. So serial measurements of IOP, recordings, optic disc changes, and vision fields are very useful for the diagnosis. In terms of preventive measures, pre-existing glaucoma, you got to take care of the pre-existing glaucoma before you do cornea transplants. If you do a trephination and in a patient with very high pressures, you're looking towards suprachoroidal hemorrhage on the table. You don't want that. So control your glaucoma surgically if it's not medically possible, doing a trab or a tube or whatever you're comfortable with before you take the patient to the operating room. Perforated corneal ulcers, operate ASAP to avoid cynical adhesions. During PKP, oversize the graft by at least 0.5 millimeters, oversized donor button, deep stromal bites about 90% depth, goniosyncytial with viscogoniosyncytial open sky is a very useful and painful technique. Now sometimes it tends to bleed depending upon how hard the eye is. They tend to bleed a lot. If there are bleeding blood vessels, if the blood vessels are there that tend to bleed, you can cauterize. Don't forget, you can use cautery on the iris, open sky technique. Even if it's not open sky, cauterizing the iris blood vessels is a technique that can be done under visco cover. Arthroplasty for floppy iris syndrome patients, viscoelastic washout, and careful wound closure to prevent wound leaks. Management has been extensively dealt with. I'm not going to go too much into it. Topical carbonic anhydrase, even though we wrote about this, I'm not a strong believer in it. In the classic paper that we put together for Survey of Ophthalmology, I did mention, because somebody before me mentioned that. Since then, I've used COSAP extensively on these patients. My impression, I think it's just a literature thing, and I've never seen this actually being induced. Prostaglandin analogs, as you know, if it is hepatic infection that caused the corneal scar, there is a risk for recurrence, as Kaufman showed it. Myotics, stronger myotics, which we probably don't use anymore nowadays, can stimulate iritis and graft rejection, and that's been documented with carbachol and really strong myotics. 1% pilocarpine probably does not induce the same. So a lot of this literature came from 1960s, 1970s, and 1980s when people used to use them, and we just don't use those. At least in my practice, I don't use these drugs anymore. Benzalkonium chloride is the #1 culprit in my opinion. BKC is the #1 preservative in all of glaucoma medications because there's not much money in glaucoma. Unfortunately, all the drops still contain BKC, even though we know it's toxic to the corneal epithelium. So it's like putting in a drop of acid into the eye, and especially if you start using this glaucoma medication soon after the transplant is done and the epithelium is trying to heal, then you can run into problems with the non-healing epithelium. Non-healing epithelium can transfer itself into a stromal melt. So be careful about that. SLT does work, as has been mentioned in the prior talk. It does work. So for somebody, especially for a keratoconus patient, when you do a transplant and the patient is developing glaucoma, you can try SLT, but anytime any procedure is done in the presence of cornea transplant, make sure that you use high-dose steroids to cut down the risk of graft rejection. Now, we published this paper back when I was a fellow in Mass Eye Deer, PKP glaucoma surgical outcomes, comparing all the studies that were done. And still, as has been mentioned, glaucoma drainage devices probably is a smart way to go. At that point in time, with all the publications, it has a higher graft ejection rate, and some of the reasons have been mentioned, which is direct contact. Anytime silicon tube gets in touch with the graft endothelium, it will fail. There's absolutely no question about it. But even otherwise, I think all of us are better surgeons now than 20 years ago. Even now, the incidence of graft rejection is much higher, even without, you forget about cornea transplant. You take a normal cornea, you stick a tube in, there's a 30% graft rejection rate in 5 years. And why does that happen? We wrote a paper in TVST published about 2 years ago. We did rabbit experiments. We think it's nutritional steal phenomena that's happening where we found a significant hypoxia and nutritional deficiency in those patients in the eyes, rabbit eyes that had glaucoma drainage device implantation compared to the other normal eye. So we think one way to get rid of that, and which is what we suggested to New World Medical, is to cut down the size of the tube. There's absolutely no need for us to have that big bore 0.3 millimeter tube opening in these patients. You cut it down by half, you still get the same outflow. Like we finding out with the Zen, the graft rejections are pretty close to zero. So why is that? I think it's the tube diameter. We really don't need a 0.3 millimeter tubes, but of course they're not going to do it right now simply because if they have to alter the tube diameter, they have to redo a $1 million, multi-million-dollar FDA study, and so none of the companies are interested in doing it. So, but my preferred technique, believe it or not, and I regret not having published on this. We've written extensively on canaloplasty. I'll take 2 more minutes. In patients with different settings, but canaloplasty in the presence of PKP, ab externo canaloplasty in the presence of PKP is the way to do this. 0 graft ejections in my hands. I've done a number of these procedures. Now, we're now doing ab interno canaloplasty too, but I don't have that number of patients for me to confidently tell you that the graft ejection rate is 0. Ab externo, I've got a nice round pupil and a blue eye that the wife loved. And then I did a DSEC, floated a DSEC on top of that. The guy ended up with 20/30 uncorrected vision. So for you to be glaucoma is simply not doing traps and tubes for every single patient that comes along. Glaucoma is a multifactorial disease process. In this case, the corneal transplants is inducing glaucoma. So a glaucoma surgeon and a corneal surgeon have to be aware of this and having the confidence to do all these multiple procedures. And when you do that, I think the results will be great and the patient outcome will be good. This is just showing the DSAC and how we refloat the graft. And so anyway, I want to thank the organizers for this invitation, and any questions, we'll be happy to answer. And I want to thank every single member here for their outstanding presentations. I learned a lot. I don't know about you guys, but I learned a lot. Thank you.
Thank you, sir. Yeah, we're open for questions. Yeah.
Glaucoma, and we want to start the patient on PG analogs.
PG? Oh, prostaglandin analogs?
Yeah.
So, theoretically speaking, anytime. Kaufman did his experiments on HSV keratitis, right? So if the patient has HSV keratitis, then the issue of recurrent HSV coming into the graft is the main question. Other than that, other transplants, you can use it immediately if you want to. Absolutely no contraindication in my mind. I don't know about...
I think you should also be very careful while using it in aphakic and pseudophakic patients because it tends to increase the CME. And if you've done combined procedures, say maybe cataracts, so the chance of anterior segment inflammation is anyway high. So reserve it as the last tool, of course, after you've tried beta blockers and adrenergic agonists. But then, weighing the risks and benefits, I think it can be used if all these situations are not there. to preclude it.
And the second question is, when it's a very irregular AC and we have been kind of able to achieve a good graft, so what glaucoma procedure do you advise? Is it the trap, the valve, or the newer cyclodestructive things which people are talking about?
So micropulse, so going back to prostaglandin analogs, I published the first paper on CME with prostaglandin and latanoprost. And I published that when I was a resident back in 1996, 98 or something, right? And since then, I use this extensively. And I have to say, a lot of literature that I myself have written, I take back that if given a chance, okay? So don't ever follow past literature, read it, use it appropriately, and then follow it. And two, I never leave a grafted eye aphakic anymore. I mean, the techniques that Dr. Radhika has shown, I use it extensively. I mean, the open sky is the simplest way for you to put a scleral tunnel, right? I mean, there is absolutely no issue with putting in a scleral tunnel 3-piece implant. So why don't you take the chance and do that at the same time as you're doing the graft? So I never leave an eye without a lens in there. So in my opinion, there should not be any more aphakic patients floating around the planet. I mean, absolutely no need. But having said that, I've used this prostaglandin analogs since my original paper that was given to FDA and is quoted in all the prostaglandin analog FDA warnings. And I think I triggered something that I should not have triggered. But it does happen, yes. In some patients, it does happen. You should watch out for it. So what was the second question?
The second question was...
irregular anterior segment.
Yeah.
So when you're doing anterior segment, I do the anterior segment reconstruction in all of these patients when I'm doing the transplant itself. Now, in the presence of anterior segment reconstruction, GDD still is the best way to go. Where I moved to now, Florida, has a lot of fungal infections with invasive fusarium infections that I'm tackling every week, every month now. And a lot of these things come with irregular anterior segment. Tube is the best way to control them. The micropulse, we wrote the largest series that we published about a year ago on micropulse outcomes. Micropulse works only for mild, moderate glaucomas, primary open-angle glaucoma. At least in the series, that 200 eyes that we published upon with 1-year follow-up. PKP glaucoma is not one of them. Anything that is secondary glaucoma, it didn't show too much in terms of success, less than 30%. So I still rely on tubes in those patients with irregular anterior segments.
And lasers? What about the lasers?
Sorry?
The lasers?
The results are very good.
Okay.
The results are very good, yes.
No, I'm talking about the lasers, the cyclodestructive lasers.
So I am not a big fan of destroying ciliary body. God created ciliary body for a particular reason. You don't want to destroy the aqueous production because it can lead to phthisis eventually. So I personally am not a big fan for that procedure. Those kind of cyclodestructive procedures, that's my last resort. I would rather take my chance of graft rejection with a tube. I put another transplant in, that's perfectly okay. But I don't want to do a cyclocryo or cyclodestructive procedure that leads to permanent hypotony.
Thank you. Thank you.
Thank you.
Thank you. Yeah, please.
Thank you. Very good presentation. I am asking 2 questions. The first question, to control astigmatism post-keratoplasty. I can do loosening for the running suture to control steep meridian, but how can I tight the loose suture in running sutures? How can I tight the suture in running suture in loose suture?
Actually, you can't really tighten it. You can only redistribute the tension. You have to adjust it in a way to redistribute the tension. You can't tighten it in an isolated place. If you are tightening it somewhere, you have to redistribute the slack to... Okay.
Second question, which is better, sequential surgery in aphakia with keratoplasty, scale fixation and penetrating keratoplasty, or combined surgery? What is better, sequential or combined surgery?
It's always
combine. You never want to go inside a grafted eye as much as possible a second time for obvious reasons, because A, the approach, B, the surgical trauma that you will inflict on the endothelium of the grafted eye, these don't bode well for the graft. The only limitation that you have is the choosing of the intraocular lens. So that is not very easy in the post-keratoplasty situation as well, because there also you have astigmatism and other factors to contend. So like Dr. Ayala pointed out right now, even for reasons of glaucoma prevention, it is better to have an IOL inside the eye. So if you have a chance, it's always better to do an intraoperative IOL fixation or a secondary IOL rather than go a second time in a grafted eye.
Okay, thank you.
So one of the techniques that I use is to drop a little bit of canalog into those eyes as I do these combined procedures and anterior segment procedures. In my opinion, it increases the survival of the graft. It decreases the post-op graft inflammation. And glaucoma is never a problem for me because I am a glaucoma surgeon, so I can take care of steroid responsiveness. So that's something that has helped tackling a lot of these post-op inflammations in these eyes.
I have a question for Dr. Ayala. It may not be directly on the subject, but you did show a pediatric patient as the first part of your presentation. It's not to do with glaucoma either, but we have had a lot of experience in our institute dealing with these babies. Congenital problems, intrauterine infections which have caused scar, or immediate post-operative period related infections which have led to corneal scarring. So even though there is so much hype about amblyopia, I'm not saying amblyopia is a hype, it's a definite a factor to contend with, but the point that I'm trying to make is that when we take them up very early, on table you can adopt some measures, some of which you showed right now, to make the surgery a success. But in a very small baby, a graft almost always is a problem. It's a tiny graft, it's a tiny baby, early suture loosening, difficulty in getting the refraction, multiple, general anesthesia sittings, all this becomes a problem. But what I have found is when the baby waits for some reason, it's never your reason, you always tell them to get it done early for amblyopia issues, but if they take their time to decide and come back, when you do the graft a little later, setting aside the issue of amblyopia, they do much better when they are about 2 years or 2.5 years or 3 years. So would you agree with this, or is amblyopia still a driving factor to do these surgeries very early? In my opinion, there's a whole lot of other baggage on one side, only amblyopia on the other side. So if I can get to operate this baby when the baby is 3, then a lot of issues are saved, and we can do some aggressive treatment post-operatively for the vision deprivation.
So if I left the impression that you should jump on every corneal scar that a baby has with a transplant immediately, I'm sorry. That's not what I was trying to say. I agree completely with what you're saying. If you don't need to do a transplant in these babies, don't do it, because the baggage that comes with the transplant in the baby is very, very difficult to manage. I hate doing transplants in babies, not from the surgical point of view, because of fear for the post-op management in these babies. And so if you can delay doing the transplant, in fact, in some babies, if they have light haze in the cornea, I'll leave it, because the results are much better with the natural light haze corneas than with us going on doing a transplant and taking on all the risks of the transplantation, etc. In that particular baby that I showed, there's absolutely no way. We didn't even know if the baby had any vision at all in that particular patient. So as soon as the baby was born and the baby was brought to me, I did bilateral transplants in her in the same setting, and she has done well. But that's not every single baby that comes across. And I completely agree with you. Don't jump to do a cornea transplant. In fact, I would say avoid doing a transplant if possible in a baby. If the vision is 2200, I can tell you this, even after transplantation and everything else, you're not going to get anything more than 2200. So leave the baby with the natural cornea and be happy with it. This is like I've shared many podiums where for non-ophthalmic eyes, people say, oh, we're going to use this piggyback technique and etc. I'm like, why do you want to complicate an anterior segment that's already crowded, right? So a patient who has got a +16 diopter hyperopia, now you're making her into a +6. You think she's not going to be happy? She'll be ecstatic. right? And the same thing in this situation. Yes, caution is the word. I agree completely with what she said. Don't jump to do a cornea transplant unless it's absolutely essential in a baby. Any questions? Thank you.
Thank you. Thank you very much. I think we'll hand over the podium to the next course. Thank you, sir. Thank you so much for your inputs.